Good morning and welcome to Internal Medicine Grand Rounds. I'm Dr. Kim Allen Williams, for those of you who are online. And we have a marvelous, very informative Grand Rounds that we're looking forward to in our nephrology area, talking about autosomal dominant polycystic kidney disease. It'll be given to us by Dr. Pranav Garimella. He and I share some Chicago background and the Russ Stroger Hospital, Cook County kind of system. It was fun catching up. But he will get a formal introduction by our wonderful leader in nephrology, Dr. Rosemary Husa. Dr. Husa?
Thank you, Dr. Williams. So we have the pleasure of inviting Dr. Garimella for our Grand Rounds. This is like 3 years in the making. We have been trying to get him here. And he left warm, sunny San Diego to come here and talk in cold, gray Louisville. But anyway, on to the introduction. He got his MD,
Judy,
his MPH in epidemiology at the University of Minnesota, did his medicine residency at Cook County, Chicago, as was said, and nephrology at Tufts. I actually asked him what he wanted me to talk about because his CV is really big. So I was like, oh, what do you want me to talk about? So his awards include the most valuable professor in the Division of Nephrology at UCSD. He was the Medical Staff Physician Professionalism Award in 2024 and Neph Hero Award for Nephew, which is a education form for nephrology in 2024. He is the director of the UCSD Adult Autosomal Dominant PKD Center of Excellence, and he does translational research. So he sees patients, he does the administration for the Center of Excellence, but he also has NIH funding to investigate polycystic kidney disease. He is the Acute Dialysis Services medical officer and the CMO of the American Kidney Fund. And he is co-director of the GlomCom PKD program. As I said, he's NIH funded. He looks at tubular damage in PKD. And he collaborates with some of the investigators here at UofL. So he spent some time with Leah Siskin, who does work in cisplatin and kidney disease. And every time I turned around, it was like someone wanting to collaborate with him. Let's do this, let's do that, let's do this. So I think that collaboration will continue even after he leaves. He has mentored multiple medical students, and he has over 90 publications. So please welcome our Grand Round speaker.
Thank you, Dr. Williams. Thank you, Dr. Youssef. I don't know if I live up to all those expectations, but I will do my best. And it's been fantastic being here, my first time in Louisville and Kentucky. So these are my disclosures as I talk about polycystic kidney disease today. You know, most of you have heard, seen patients, perhaps even. My research is in the area, and I do serve as a speaker for Otsuka, which makes the only drug for PKD. So that is relevant here today. So I'll start off with a story, which is how I like to tell things. Let's talk about Melissa. She's 54. She has PKD. She's known this for a while because her mother had PKD and ended up with kidney failure, which is what happens with PKD, unfortunately. Her current kidney function in GFR is at 28 ml per minute, which puts her in CKD stage 4. She's had some kidney stones. She's had urinary tract infections, and she wants to try and slow her kidney function loss. She asks whether her 25-year-old son should be tested. As you can see, this isn't your run-of-the-mill chronic kidney disease, which is silent. PKD has symptoms, and that will be a theme that we'll see as we keep going through the rest of the talk. We'll talk a little bit about epidemiology and pathophysiology, but focus on what we do to make the diagnosis, how we rule out PKD, which is often the question as patients come to clinic with 1 or 2 cysts, and talk about the clinical manifestations and why we need to prognosticate, what we can do to preserve kidney function. And then I'll close out with a few slides on why we focus on more than kidney function when it comes to PKD. So we've known about PKD for a long time. It was first documented in the Prince of Transylvania, which is a little different from this guy. But this is actually Stephen Báthory. So Stephen Báthory was the Prince of Transylvania. And if you look at all of his pictures in the history books, they're all depicted with him in these big flowing robes with some kind of protruding abdomen. And on his autopsy, his physician in chief noted that he had several cysts. Fast forward 200 years, Matthew Bellil actually called them false hydatids because you have hydatid cysts from tapeworm, which used to infect people. And he called these false hydatids because they're like, hey, there are no worms in these, but people have cysts in their kidneys. And in 1888, the term polycystic kidney was first coined. It took almost 100 years for us to understand why polycystic kidney disease happens until in 1994, Peter Harris, who's now at the Mayo Clinic, actually identified the PKD1 gene to be the causative agent. Since then, we've identified several others. So how common is PKD? And that depends on how you look and where you look. A lot of the data that we have comes from Olmsted County, Minnesota. And if you look at the records from the Mayo Clinic, they classified patients based on imaging and history as having definite, likely, and possible. And you can see that likely PKD was 47 in 100,000, definite was 68. But if you use something that's a little more specific, which is genomics in large databases, and this is databases using in 123,000 patients who had whole exome sequencing and another 78 who had whole genome, you can see that the prevalence of having PKD with the high confidence is almost 93, and likely pathogenic variants causing PKD was 174. So based on those estimates, in the United States alone, we probably have between 250, 300 to 600,000 patients, and worldwide anywhere between 5 and 12 million patients. So it's pretty common. It is the most common inherited kidney disease and the fourth leading cause of kidney failure worldwide. So as the name suggests, it is autosomal dominant polycystic kidney disease, which means that one parent can transmit it to a child. There's 50% likelihood of transmission. So each child has a 50% chance of getting the disease if the parent has it, and it has 100% penetrance almost. What does that mean? Unlike some genes which may manifest or not with diseases and need a second hit, or they need, another modifier gene, these genes will manifest some form of the disease. The severity and the spectrum may vary, but you will see some manifestation of the disease. That's true in 80 to 90% of patients. Sometimes in 10%, you don't have a family history. And that's unfortunately not common. I have patients who know their biological parents and don't have PKD. After all, every mutation has to start somewhere. And so in 10 to 20% of these cases, you have de novo mutations. Sometimes their parents may have had mild disease and that has not manifested completely. And this now manifests in the child. So again, just know that because parents and siblings and uncles and aunts didn't have a history of PKD, this is not, you can't rule PKD out. And that's important because for the first time, we actually have guidelines for polycystic kidney disease that came out in 2025. So the KDIGO ADPKD guidelines actually give us a framework of understanding PKD for the first time. And what they say is, yes, we've called it PKD for far too long. What can we do now that actually tells people what it is? And the first recommendation is that consider genotyping these patients. So if you've not got a genotype, you can just call it PKD like you always did. But if you've actually tested for that PKD1 mutation, which causes 75% of all PKD, you call it ADPKD PKD1. If you find a PKD2 variant, you call it ADPKD PKD2. And if you don't find it, or you find something that has a variant of unknown significance, and we'll talk about that in a little, you just call it ADPKD again. And I'll tell you why this is important. So PKD1 accounts for about 75% of all known PKD cases. PKD2 accounts for about 15%. And you have a handful of genes that I'll show you in the next slide that account for about 3 to 4%. That still doesn't add up to 100 because we have about 7% that come back negative on genetic panels that we currently use today. So even if you don't have a family history and your genetic panel comes back negative, if the phenotype fits, if clinically they have cystic disease, if they're losing kidney function, it probably still is PKD. You just haven't identified the gene. But does everyone need genetic testing? Well, not necessarily. It's recommended to offer it because if you've got a strong family history of kidney disease, people are losing kidney function, they've got massive enlarged cysts that I'll show you some images of, that's probably PKD. But if there's no family history, if people are trying to conceive and they don't want to pass PKD on and want to do pre-implantation genetics, which can be done, if you've got atypical presentation of very early onset, because kidney failure usually occurs in the 6th decade of life. If it happens before, you might want to consider it. And if you've got syndromic features, extra-renal manifestations outside of what is commonly seen, that's another reason to consider it. And this is just a snapshot of the spectrum of genes that can be associated with cysts, not ADPKD. None of these are ADPKD genes. So you've got autosomal dominant polycystic liver genes. You've got autosomal dominant tubular interstitial kidney disease genes. You've got genes that cause kidney stones that have cysts. You've got collagen diseases like Alport syndrome that can be associated with cysts sometimes. Von Hippel-Lindau disease, tubular sclerosis, all of them can have cysts in some form or the other. And none of these are necessarily due to PKD. So just knowing that there is a large spectrum of diseases that cause cysts, and not all cysts is ADPKD is important, because the moment a patient sees a cyst on their kidney ultrasound, they Google kidney cysts or polycystic disease, and it is a slippery slope for them the moment they see what, is associated with PKD. But again, this is just the spectrum of PKD. On the right hand here are the 3 most common genes. So PKD1 truncating mutations. So they cause the most severe form of kidney disease, kidney failure at the age of 54. If you've got PKD1 non-truncating disease, the kidney failure is probably in the early 60s. If you've got a PKD2 mutation, the median age of kidney failure is about 78. So knowing the type of mutation actually prognosticates how far along a patient's life they might end up with PKD. And then on this left side here, you've got these minor genes, those that account for that 3 to 4% that I had mentioned, NEC8, DNAJB11, ALG genes, GANAB, and the third most common PKD gene is IFD140. So if you pick up any of those on a genetic panel, the patient still has ADPKD, just not from PKD1 or 2, and their prognosis is typically much better. Lots of mechanisms as to what's happening. People are very, very interested in understanding this. The primary loss is in the function of polycystin 1 and 2 here in the primary cilium, and this leads to decreased intercellular calcium, increased cyclic AMP signaling. Vasopressin is a potent stimulator of increased cyclic AMP, and then we have activation of protein kinase A. So again, activated protein kinase A leads to increased MAP signaling and proliferation of fluid within the tubular cysts. So again, it is a primary tubular disease. It's not like lupus. It's not like membranous. It's not like all the other kidney diseases that we think about traditionally that start in the glomerulus, even diabetic kidney disease. So PKD is a inherited tubular disorder. So with that in mind, how do we make the diagnosis? So this is an example here. You've got a 43-year-old man with possible PKD and a kidney function of a GFR of 85, no family history, and you can see these small white dots here that are cysts. So this is data from the Mayo Clinic where they looked at the number of cysts in almost 2,000 potential kidney donors. So these people are healthy, remember, they're trying to take a kidney from them.
Oh, wow.
So they said, let's look at the number of cysts. And this is their age groups by each decade. So from the 20s to the 60s, and apparently they take donors in their 70s as well, or at least potential donors. And they looked at the number of cysts more than 5 millimeters in size. And as you can see here, the number of cysts keep increasing. So how many of them had 1 cyst, 2 cysts, and 3 cysts? So it's pretty common to see an isolated cyst or 2 in young, healthy people who could be kidney donors. This is obviously a concern if they have a family member now who has cystic disease, because you need to rule out that they don't have cystic disease. And so there's a cutoff that's been suggested, which is the 97.5th percentile of cysts greater than 5 millimeters. So if you're in your 40s, you need to have at least 4 or more cysts for men or 3 or more for women. And if you're in your 60s, you probably need to have over 10 cysts in men and 11 cysts in men and 5 cysts. So again, this is a suggested cutoff for identifying what might truly be polycystic versus just incidental cysts, which is what we're talking about. And so you can run down this diagnostic algorithm from the PKD guidelines again, but I'll just summarize that you have to first identify whether there is a family history or not. And I think that determines what kind of path you take. If you've got a family history, you can start with an ultrasound. And if you've got a diagnosis confirmed, you can stop there. Because you have a family history, you've got an ultrasound, you've got cysts, end of story. That is diagnostic. You can do genetic testing to verify what type of mutation, but you don't have to. It becomes a little more tricky when incidental cysts are picked up on an ultrasound, because that is the most common reason people get referred. If you've got a family history or you've got familial testing, you come back and do the same thing here. But if you don't, then I think it's worth going back and looking at that slide that I showed you previously and said, how many cysts do they have? What age category do they fit into? And how many of these cysts are actually larger than that 5 millimeter cutoff? And if you don't have a family history, you can, again, get genetic testing. Otherwise, you just follow up and see, are there cysts growing? Are there kidneys growing? So that you understand whether this is behaving like PKD. But we can actually give you some cutoffs. So this is for adults at risk of PKD who using ultrasound, which is what is recommended as the first screening test of choice. This is in people who have a positive family history. And they further stratify that saying, if these patients have a known family history of a PKD1 mutation, if they have a known family history of a PKD2 mutation, and if they don't have a known genotype in the family. And you can see here, depending on the age, you need more cysts in each kidney. So if you're in the 15 to 29, you need 3 or more cysts in each kidney. If you're at 60 or above, you need more than 4 cysts in each kidney. And if there's a PKD1 mutation, it's 100% positive. If you know that the family has a PKD1 mutation, that's 100% positive. If it's an unknown genotype, again, you need to have more cysts, and the positivity can be as high as 100. The sensitivity, obviously, is a little lower if you have an unknown genotype, because you can have other causes as well. So bottom line is that you need more cysts per kidney as people age if you need to make the diagnosis. What about if you need to exclude the diagnosis of PKD, which is often the case? And so if you've got, this is the positive predictive value, again, based on whether they have a PKD1, PKD2 gene, and the negative predictive value. And so if you look here, if you've got patients who are in that 15 to 30 age group, the negative predictive value is only about 90%. So you do have the risk of missing patients and misclassifying them as not having PKD. And that's why we do not recommend an ultrasound to rule out a diagnosis in young patients. If you get to the age of 40 to 50, everyone has cysts by then. So if you see no cysts, or if you don't see more than 2 cysts, that's almost 100% predictive for them not having the disease. But in young patients, if you don't see anything on an ultrasound, you probably need a genetic test or an MRI to rule them out. This is just using the MRI criteria, and you need far more cysts, because the MRIs pick up smaller cysts. So you need more than 10 cysts in an MRI in a young person, and more than 5 cysts if they're older, to actually rule in the disease again. But ultrasound remains the gold standard screening criteria unless you have a higher need to go to an MRI. So now that we perhaps have identified what patients may or may not have cystic disease, assuming that we've made this diagnosis, what does this mean? PKD is a systemic disease. We call it polycystic kidneys, but really, if you look up and down, you've got renal manifestations on your right, you've got all these extra-renal manifestations on the left. Intracranial aneurysms, pericardial effusions, valvular abnormalities. Heart failure, we're noticing now, is far commoner than we previously thought. Liver cysts, pain, hernias from it, and even seminal vesicle abnormalities leading to male infertility. And so it's much more than just a kidney disease. And I'll talk about a few of these extra-renal manifestations, because again, we need to understand how to manage all of these for our patients. So this is a snapshot of what patients expect and what they go through when they have polycystic kidney disease. You've got age here on the x-axis, going from about age 15 adolescence to about 60. So this assumes typical polycystic kidney disease due to a PKD1 mutation. And the interesting thing here you see is that GFR is not a linear trajectory. It's not doing this. Your GFR remains stable almost until their fourth decade of life, maybe even their fifth decade, and then rapidly starts dropping. That is because the remaining nephrons and the glomeruli are hyperfiltering. So GFR is a very late marker for kidney function decline in patients who have PKD. You're already hyperfiltering for decades before your GFR starts to rapidly drop off. And once that drops off, the rate of kidney function decline is anywhere between 2 to 7 ml per minute. So if you take someone who had a GFR of 70, for them to get down to a GFR of 10 could be 15 years. So a 35, 40-year-old could end up with kidney failure by the time they're 50 or 55. But that's not all. All along that course, you have all these chronic symptoms. Hypertension is probably the most common sign associated with kidney disease, well before you see GFR declines. Pain and proteinuria often present, which can be related to activity, kidney stones. You have urinary tract infections, cyst ruptures become more common. And so each of these blue dots here shows the frequency of some of these symptoms as you go through stages of chronic kidney disease. So the larger the kidneys, the more severe the disease, the more symptomatic progression you have. But this can be variable. Some patients have stones, some patients never have stones. Some patients have urinary tract infections, others don't. And so understanding what phenotype your patient fits into is really important. And this is an old slide, it's from like 26 years ago now. It's an image looking at kidney failure in people who have PKD1 and PKD2 mutations. And you see here, back then, the median age of kidney failure was 54 for PKD1 and 74 for PKD2. And every time we were looking at kidney disease trials, we were trying to change the GFR slope here. That's too late. You're already on that downward slide. Ever tried stopping a kid coming down a slide? Doesn't happen. You might slow it transiently, but they're going to come down. What we need to do is move our endpoints far more proximally. Start intervening when there is risk, when we identify risk, not when there is kidney function decline. And how do you identify risk? Well, perhaps nothing better in PKD that we know of right now than saying, how big are the kidneys? So this is data from the Consortium for the Renal Imaging and Study of Polycystic Kidney Disease, or the CRISP study. It's about 20 years old now. Jared Grantham and his group looked at this data. They looked at 214 patients and did MRIs on their kidneys serially for 3 years. The blue dots here are women, the red dots here are men. And what you see here is that irrespective of the age that these MRIs were done, the kidney volumes increase in size year over year. 7-8% increase in size in kidney volumes approximately each year. And what they found was that the larger the kidneys, the more rapid the kidney function decline. And so it took a decade from this to 2015 for the FDA to actually approve total kidney volume as a likely surrogate, not even a surrogate, a likely surrogate for clinical trial endpoints. So this just gives you an example. On the right, on the left there, you have a 43-year-old man with a PKD1 mutation. You can see these massive kidneys filled with cysts. The liver is filled with cysts. The entire abdomen is taken up with cysts. On the right here, you have a 43-year-old man also, but with a PKD2 mutation. The kidneys are still enlarged. They still have multiple cysts, but it's not quite the same. And so those large kidneys filled with cysts due to a PKD1 mutation are going to have a worse prognosis compared to the PKD2 mutations. And we now know how to use this. So we've moved away from saying, just kidney size to how does kidney size matter? Does it matter whether it's the same size at age 40 versus age 20 or age 60? So this is the Mayo classification that looks at age on the x-axis and the height adjusted total kidney volume. So you add up the kidney volumes from both kidneys and divide that by the height in meters, and then you get a classification. And what that tells us, if you're at this low classification, if you've got smaller kidneys, you've got a 2.4-year, 10-year risk of kidney failure. If you're in Mayo 1E, which is this large kidney class here, which was that prior patient, you've got an almost 66% chance of kidney failure in 10 years. So this is prognostic. How do we use this? We actually use this to decide who gets disease-modifying therapy, like I'll show you, get patients into clinical trials, because no one can run a clinical trial for 20 years. You can't recruit all these patients in Mayo A and B. They're never going to end. You'll never find a funder. You'll probably retire by then. But if you've got high-risk patients, you can look at changes over 3 to 5 years. And this again shows you the GFR decline annually, assuming somebody starting from 70 to 80 GFR. You can see that if you're Mayo 1E, within 10 to 12 years, you'll end up with kidney failure. If you're Mayo 1A, 20 years later, you'll have mild kidney disease. So knowing kidney volumes is key. But it's not just the kidney volumes. Remember, I spoke about the genetics, and I told you that PKD1 and PKD2 mutations have different rates. This is data from France, which created a score and said, we'll give you certain points for clinical characteristics such as your age, hypertension, having stones or cyst rupture before the age of 35. And then we'll give you points for your PKD1 mutations, 2 if it's non-truncating and 4 if it's truncating. And then you get this risk score. And you can see that if you're a PKD1 truncating, you're already at an immediate risk. And you can see here the Kaplan-Meier curves by low, intermediate, or high risk. The kidney failure median age for the high risk, again, it's about 73, and it's about 48 if you're in the high risk category. So even if you don't have kidney volumes, the genetic test alone will tell you when patients may have kidney failure. So again, the importance of understanding kidney volumes and your existing tools is key. So you've got these genetic tests, you've got kidney volumes, you can prognosticate patients and say, oh, they have a Mayo 1A class, or they have a low pro-PKD score. They have a slow GFR decline. We just, optimize their management as we would do. We manage their hypertension, we manage their diabetes if they have it, etc. If they've got Mayo 1B or intermediate risks, you might want to reassess their rate of growth, maybe do another MRI, see that they don't change classes. And if they've got high-risk features, that's when you want to start disease-modifying therapy. So that is the use of these prognostic tools. Because we know that a variety of factors can affect kidney disease progression. Most of these truncating mutations start early on. You see GFR decline. You see all these late minor genes causing kidney function decline in patients in their 70s. You've got lifestyle factors, of course, smoking, obesity, high salt diets, all of them increase risk of kidney disease. And sometimes you've got different genes that can act as modifier genes. So there's a whole spectrum of things that probably add on to what is happening for that individual mutation, with that deck of cards that you're dealt with when you're born. So how do we then go ahead and preserve this kidney function? You've diagnosed the patient, you've risk stratified them. Now you need to do something to actually help them, because otherwise we're not doing much. So blood pressure. Everyone loves blood pressure management. This is what we do in kidney disease all the time and in cardiology. And if you look to see what we use to target for blood pressure goal, you'll see that in PKD, the recommendation is to actually target a blood pressure less than 110/75 if patients are below the age of 50 and they have a normal GFR. Now, this is far more aggressive than any other blood pressure recommendation you'll see out there. And this comes from a fairly large study for PKD standards, the HALT study, which looked at 560 patients, and they randomized them to an ACE or an ACE plus an ARB, so dual RAS blockade, which we no longer do, by the way, and 2 different blood pressure targets. So blood pressure target less than 110 or standard blood pressure less than 130. And what the investigators found was that high intensity blood pressure targets led to slower cyst growth. Doesn't matter what the drugs you use, as long as you use one form of RAS inhibition. Dual RAS inhibition is associated with more complications, so we don't use that. But as long as you use one RAS inhibitor and then your choice of drugs, as long as you get to a target less than 110, you can actually slow cyst growth. We don't recommend that in older people or those with chronic kidney disease with a GFR less than 60, just because they tend to have more acute kidney injury events. They're older, they might be frailer. But if you've got young patients, an aggressive blood pressure target is what is recommended. And then that brings us next to the only disease-modifying therapy we have, which is vasopressin antagonism. And over the last 25 years, there's been emerging data showing how suppressing vasopressin in rats that had mutations for polycystic kidney disease could actually suppress cyst growth. And giving vasopressin antagonists, so this is your polycystic kidney disease rat, which had vasopressin present, male and female rats. You knock vasopressin out, and then if you knock vasopressin out and then give back vasopressin, you see the presence of cysts again. And so this led to the development of tolvaptan, which is a vasopressin 2 receptor antagonist, as the first treatment for polycystic kidney disease. And this was the TEMPO trial. So this randomized 1,400 patients. So big trial for polycystic kidney disease. 1,400 patients for a rare disease is huge. And they randomized patients to tolvaptan or placebo. And this is change in kidney volumes between baseline and 3 years. And what you see here is the tolvaptan arm had about a 50% slower progression of kidney volume growth year over year. 5.5% in the placebo arm compared to 2.8% in tolvaptan. So tolvaptan significantly slowed cyst growth in PKD. We followed that up. We're looking at changes in serum creatinine, so 1 over serum creatinine. And again, you can see that there's about a 1.2 ml per difference GFR in creatinine clearance. This translates, when you look at estimated GFR, about a 1.3 ml. And so the reduction in GFR was about 30% lower per year in people treated with tolvaptan. There was a follow-up trial, so just based on TEMPO 3-4, Europe, Australia, Japan, and Canada approved it. The US wanted another trial, so we did the REPRISE trial, which was for 1 year. And again, you see the same thing. This is change in GFR. You see about a 26% benefit in TEMPO 3-4 compared to a 35% here. So based on these data and an open label extension, FDA finally approved tolvaptan in 2018. So for the last 8 years almost now, we have a drug that actually can slow progression. It's not stopping it. Let me be very clear. We're not reversing it. We're not curing it. We're not stopping it. We are slowing it. We're slowing it by about 25, 30% compared to not taking placebo. And you can see here, if we model that out, what does that mean for patients? And patients say, what does a 1.2 ml GFR per year mean? Because they're not thinking in terms of that. Well, if you started tolvaptan based on any of these trials, if you look at TEMPO 3-4 data and say, hey, if your GFR was 90 and you started tolvaptan, you would probably have a 7-year benefit to reaching kidney failure compared to if you did. If you started when your GFR is 45, you probably have a 3-year benefit. If you look at the other trial, the REPRISE trial had even more pronounced benefits. There was almost a 7-year benefit if you started by the time your GFR was 60. So again, talking to patients in terms that they understand, saying if you took this drug for X years, you have Y years of not needing a transplant or dialysis, makes sense. 1 ml per year does not translate. And this holds true. This is modeling studies done across stages of kidney disease. So whether you have stage 1 kidney disease, stage 2 kidney disease, or stage 3 kidney disease, compared to the blue bars, which is placebo, these dark bars on top is the years added with tolvaptan therapy. And again, it comes out to be approximately 30% benefit. So again, going back to these TEMPO and REPRISE studies, the data, even from real life and real world data, suggests that there is a benefit. So tolvaptan helps. And so the PKD guidelines said tolvaptan should be offered to adults with PKD who've got a GFR greater than 25, because that's what the trials enrolled, and they have rapid risk of progression. What is rapid risk of progression? Well, you have family history of reaching kidney failure before 60. You have at least Mayo 1C, and have in high risk pro-PKD scores, or you've got a historical rate of GFR decline. And you can't explain that with diabetes or renal artery stenosis or any such thing. And typically we start at 45 milligrams in the morning and 15 milligrams at night. Why that odd dosing? Well, turns out that tolvaptan, because it blocks vasopressin, makes you pee. It will keep you up all night. Patients have urine volumes anywhere ranging from 4 to 7.5 liters a day. So if you give them a huge dose of tolvaptan at night, they're not going to sleep and they will hate you. And so we found that you can suppress tolvaptan adequately, 45 and 15 milligrams dosing. And even that is sometimes hard. So patients go back and you can actually go to a lower dose. And as long as you suppress that urine osmolality to probably less than 280 to 300 osms per liter, which is what trials went back and looked at, and they found that that correlated well with progression. So as long as you suppress vasopressin levels, get your urine osmolality that low, your benefit from that tolvaptan is probably there. But there are risks. The aquaretic side effects are probably the most problematic to manage. Patients feel thirsty, they have to drink water, they need to find restrooms. Not all professions can take it. I've never found a long-haul truck driver who said, put me on tolvaptan, right? So it just doesn't happen. And so you need to think about what the costs are. When it started, there were patient assistance programs, but it was $13,000 a month.
Yeah, I guess.
And you have uncertainties. Yes, it slows GFR decline, but we don't have any hard outcomes to say that it actually prevents kidney failure because no one has done a 10-year trial. So we're still waiting on some of this real world evidence. And so we definitely need more drugs. But the biggest concern was the fact that it actually causes AST and ALT elevations. About 5% of patients have AST and ALT elevations. This slide is courtesy of what should be. And there's a 0.2% risk of severe hepatotoxicity. But most often these happen within the first 18 months. And these transaminases sometimes increase after discontinuation, but most patients, it completely resolves in 1 to 3 months. So it's a reversible, idiosyncratic drug-induced liver injury. It's irrespective of whether patients are taking statins, irrespective of whether they have any other kind of medications. There's no interaction, irrespective of the stage of CKD. Doesn't matter if they have liver cysts or not, because there are no V2 receptors on the liver anyway. So this has nothing to do with the drug acting on the liver. And so if you have these elevations, typically we hold the tolvaptan, reassess in 48 to 72 hours. And if it's continuing to be more than 3 times the upper limit, we stop it permanently. If it's within that 1 to 2 times, we can reinitiate tolvaptan. And then patients actually surprisingly tolerate it more. I've had at least 2 cases where I've reinitiated it after a couple of weeks and they've done well. So again, it's not an absolute indication to stop, but if it's more than 3 times the upper limit of normal, that's what we do. And just going back to that benefit that tolvaptan gives you. So you have to say, well, these LFT abnormalities, that urination, is that 1.2 ml really worth it of GFR? This is just putting into perspective the trials of renin-angiotensin-aldosterone inhibition in the RAIN data, renal study, INDT, and even SGLT2 inhibitors with cretins. This is the benefit of GFR per year compared to tolvaptan studies of 1.27. So we use a lot of drugs that have the same degree of benefit, perhaps not the same degree of side effects necessarily, but considering that patients have no other option, this is something that we should at least offer all our patients and let them decide if their lifestyle and their complication rate would allow them to choose tolvaptan over not having anything else. So if it's just about suppressing vasopressin, why not drink water? You could drink water. There's a great editorial from 2006 from Jared Grantham that says, treatment for tolvaptan, it's water, stupid. But turns out that keeping up with those amounts of water that you need to suppress is really hard. This is one randomized trial from Australia that tried a prescribed water intake compared to an ad libitum. They had 184 patients. The mean difference in osmolality was not much, just 90 osms per kilo. That was the difference. Just think about that when you can suppress your urine osmolality from 1,200 down to 100 or 50 even. The difference between the 2 groups is only 100 milliosms per kilo. And only 52% of them could even achieve that target. A lot of crossover, and you didn't see any differences in kidney volume or GFR decline. So again, I'm not saying water doesn't work. I'm just saying it's harder to do, and we don't have the evidence that it works. And so in my patients who drink water on the low-dose tolvaptan, I don't max out if they've already suppressed their osmolality because I'm not sure if there's a benefit to that. And what we know is that patients who maintain a urine osmolality less than 280 do just as well compared to a lot of the others. So again, taking patient preferences into consideration is important. We know that water intake is important. We spoke about that. Salt restriction is good for most things, and there's evidence to show that the amount of salt is really associated with progression, as with hypertensive outcomes and anything else with kidney disease. Obesity has an association with chronic kidney disease development. So if you look at any of these HALT trials and everything, and you look at visceral adiposity and the progression of kidney disease, as expected, even in patients with PKD, having visceral adiposity is bad. Smoking is bad. Exercise is good, except for perhaps if you're into kickboxing, you're into football, things like that, where you're going to get slammed. The number of college kids and high school kids I hear about who first find out that they have PKD because they've bled after they were tackled in football is not trivial. We used to think that coffee will upregulate cyclic AMP and cause cyst proliferation. Happens in mice. There's no evidence in humans, and you will not believe how many of my patients are thankful that they don't have to stop coffee. It's observational data, at least in humans, that there's no association. Nobody's done a randomized trial of coffee intake in PKD, but small mercies, at least we don't find evidence of progression in humans. We can talk about animal protein versus plant protein, and obviously there's benefits of plant-based diets for a lot of things. There's no data in humans anywhere yet about how it affects PKD directly, but it does affect several of the pathways that we spoke about earlier, such as increased fibers and polyphenols that can decrease cyclic AMP activity, that can increase cyclic AMP activity, which is critical, that can actually decrease the mTOR activation as well. These red boxes and their arrows indicate all the dysregulated pathways in PKD that cause progression. And these green boxes and the arrows indicate how they might have an anti-inflammatory effect and decrease cyst growth. No data yet. There are pathways that potentially affect, but we'll have to wait and see. But what is interesting is keto diets, as this comes up a lot in polycystic kidney disease. And this was one trial of 66 patients. There's a much larger trial in Europe ongoing right now that looked at a mixture of a plant and an animal-based keto diet. So they did have a large ketogenic diet from plants also in this. We had a control group, and you had a water fasting group. And they looked at outcomes. And as expected with any kind of a keto diet, you see higher uric acid, higher lipids, people develop the keto flu. But your body fat goes down and their ketones obviously went up. Interestingly, this is data in change in kidney volume. The red graph here is the total kidney volume, and you can see compared to the control or the water group, the median kidney volumes here are lower. So even at 12 months, at 12 weeks, there was some benefit of a keto diet in slowing kidney volume growth. And of course, the liver volumes change significantly once somebody goes on a keto diet, just because the changes in glycogen storage that happens. There are a couple of other studies that are ongoing right now, and we're hoping for this. But when patients with PKD come, they will ask you about keto diets. So just be aware that there is emerging evidence that whether supplementation with ketones helps. There was a paper that was out just in January that showed that there might be a benefit. We just need a little more rigorous data before we can actually prescribe it to everyone. Outside of that, there are a lot of other therapies being developed. Metformin, again, because it activates AMP kinase, it inhibits mTOR. There's a large study out of Australia, Canada, and any country that has centralized healthcare because they want to keep costs down. So we're not part of it, but the rest of the world is trialing metformin for PKD. We're looking at SGLT2 inhibition. There's concerns that it might raise vasopressin, but preliminary data, at least in humans, have not shown that to be associated with progressive disease. We have bempedoic acid, which is an anti-cholesterol medication, which is being developed. And then we have newer drugs, these RNA therapeutics. Vasopressin is a drug that Novartis has that is starting a phase 2-3 trial, hopefully sometime this year. And it's an anti-MER17, so microRNA 17 inhibitor. It's an oligonucleotide, has very good preliminary data. And then a couple of other monoclonal antibodies and gene-based therapies that are actually going to the polycystin itself. So it's an exciting time for PKD research to prevent GFR decline, but that's not the end of it. Like I said, we have a lot more in PKD that happens. We have patients who have polycystic livers, huge livers. They have compressive symptoms, shortness of breath, fatigue. They have abdominal distension in the upper abdomen, they can't eat, they have early satiety, they lose weight, they get malnourished. And polycystic liver disease is more severe in women. And there is evidence that the cysts in the liver are estrogen responsive. And so as there is increased estrogen exposure through the course of the lifetime, pregnancies, exogenous estrogen, we think that that has an effect. There's no data to show that decreasing exogenous estrogen or suppressing endogenous estrogen is associated with lower cyst growth, but mechanistically, this seems to suggest it. And almost 80% of liver transplants are in women. So again, showing you that there is a sex difference there, unlike with kidney transplants, which are similar. Well, kidney failure, which is similar. Kidney transplants in women are lower, and that's an entirely different, talk, but we won't go there now. But there are some treatments for polycystic liver disease. Somatostatin analogs like octreotide and lanreotide, long-acting ones, have been tried. They can reduce cyst volumes. It's hard to get. It's expensive. A lot of insurances don't necessarily cover it. The mTOR inhibitors and tolvaptan don't really act on the liver, so there's no benefit there. Most patients end up needing aspiration or laparoscopic fenestrations. And like kidney transplant, liver transplant is curative. And the interesting thing to remember is most of these patients don't have loss of synthetic liver function. They're not behaving like your cirrhotics. They don't have features of cirrhosis. They don't have low albumin. They don't have all the other complications. So their MELD scores are not going to be high. And so you actually get MELD exception points. And so there is guidance suggesting that the score for patients who have liver disease, if you look and have all these symptoms, so if you have class C or class D, they end up with transplantation options, and their MELD scores are usually 3 points lower than the median MELD score for that institution for transplant. So that's the exception points you get if you have polycystic liver disease. So I spoke about Melissa back then at the start. I'd like to close out with her story as well. So she was 54. She came in one day and had acute abdominal pain, had an ER visit, and was found to have a kidney stone. See this dark spot here? So she had a kidney stone, she had acute kidney injury, she needed stenting, and her GFR dropped to the teens. And so around this time, we decided that it was probably okay to stop the tolvaptan because there's no evidence of it being beneficial once your GFR reaches close to 15. So we stopped that. And like I said, kidney stones are very common. Nearly a quarter of patients with PKD will have kidney stones. And again, we go back to lifestyle, water intake to dilute the urine, salt restriction, and maintaining a healthy weight. Turns out that tolvaptan, as expected, will probably have an anti-lithogenic effect as well. You're making a lot more urine. All your tolvaptan, your supersaturation ratios of calcium and brucite will be lower. But interestingly, not just that, it actually increases the citrate in the urine when we know that citrate is protective against kidney stones. So again, a small study in 125 patients, but we know that there is evidence to suggest that tolvaptan may have an anti-stone benefit in patients with PKD. So another reason to consider it if your patients have an indication. Lots of cardiac complications in PKD. And this is not just because of kidney failure. Turns out polycystin-1 stabilizes the alpha subunit in the cardiac myocytes, and you have left ventricular hypertrophy and fibrosis. Again, going back to some of the physiological reasons as to why cysts develop and why we have these matrix abnormalities tells us why we have these abnormalities in the heart as well. Polycystin-2 modulates contractility and synchronization. You have shortening of the polycystin-2. It causes, arrhythmias. We have myxomatous degeneration of the valves. Mitral valve prolapse is pretty common in patients with PKD as well, about 5% of them. So again, knowing that valvular abnormalities, heart failure, and aneurysms, which I'll talk about, are common, is important to remember. So again, not just limited to the kidneys. Pain is unfortunately probably the most common symptom that patients will have. It can be cyst pain, it can be liver-related pain, it can be a kidney stone, it can be an infection. And as the kidney disease progresses, severity of kidney pain increases as well. And it has significant impacts on pain. So this is data from the National PKD Registry showing you how important or how much of an effect pain had across the stages of CKD on their sleep. And you can see that as they go to advanced stages of CKD. They have significant pain. They can't sleep. CKD is bad enough and causes sleep abnormalities once you get into stage 5, but having pain on top of that is not helpful. And so what you need is really a multidisciplinary team. You need to have specialists who know how to manage pain, integrative health specialists, non-pharmacological benefits. You need to have people who are willing to put in transcatheter ablation procedures, or you need to have your pain team, your anesthesia team give celiac plexus blocks, etc., if a simple pharmacological uptitration isn't helping. And sometimes why reach this last resort in patients where I need to provide them with short or long-term opiates to cover their pain, because it's unfortunately common. And you can actually do some invasive procedures. So this is a cyst. You can see in the pre and you can see post after cyst aspiration, you see the cyst disappear. So if you find one large cyst that's causing pain and symptoms, you can actually aspirate it. But very often we see so many of these cysts that you don't know where to go. And that becomes a challenge. And if you don't have a good idea, you can't keep poking at multiple cysts and trying to do that, because how many hundreds of cysts are you going to try and take fluid out of? But perhaps the most feared complication in PKD is subarachnoid hemorrhages. They are unfortunately more common. The prevalence of intracerebral aneurysms in the general population is about 3%. The incidence rate is quite low. If you look at the PKD population here, it's about 13%. So about 4 times higher, just the incidence of aneurysms. And the rate of rupture is also much higher. You can see here, it's almost 8 times higher. So especially if you have a family history, that rate of aneurysms goes up even further. So we screen everyone who has a family history of aneurysms for sure. And I'll show you on the next slide, because the last thing you want is a ruptured aneurysm. So what do? Anyone who has a family history or a personal history of having a brain bleed, you obviously screen them. Anyone who's having cardiac surgery is probably going to get screened for an aneurysm. At our institution, all patients pre-transplantation get screened. I think that can vary, but most patients do. PKD1 genotype is associated with aneurysms more commonly, so they get screened. If you don't find an aneurysm, probably you want to screen maybe once at least in the next decade. The guidance is kind of iffy about that. And if you find an aneurysm, you probably want to go ahead and look at that, with neurosurgery every few months until you make sure it's stable. So we screened Melissa. Remember, her GFR was 15, so we screened her. She didn't have an aneurysm, and we referred her for a transplant. But that next year was really hard. She had 5 urinary tract infections. She had multiple courses of antibiotics, like I told you. And every time I tried to find, what was going on, if there was another stone, I did. At one point, I saw this ruptured cyst. So she had pain from that. She had a urinary tract infection. And that brings us to, the management of this acute pain and fever in PKD. It's really hard. If you think that this is, especially once people have fever, you need to have a very high suspicion of cyst infections. And so this is different from your run-of-the-mill bladder infections and cystitis that we treat for 5 to 10 days or even 2 weeks. You need to look to see if you need a physical exam. You need to try to understand if there is a possible infected cyst. You need to get imaging done, and ultrasounds and CTs are not really great. So most often you need some kind of a tracer. You need either, you need a SPECT scan with gallium, indium, but the best is probably this FDG PET CT. And that will probably give you the best resolution. This is a regular CT. You can see the FDG PET here, which lights up really nicely, identifying the area of the cyst that is infected. And so if you've got patients who have cyst infections, again, you need to treat them with 6 weeks of antibiotics, way longer than the 4 weeks or 2 weeks or 10 days that we typically do. So we got Melissa's FDG PET CT during one of those instances after a long course of antibiotics. And I didn't see anything light up in the kidneys. This is actually physiological optics. This is what you'll see. Unfortunately here, there was this light up here in the right breast. We found breast cancer. And this is the next year's course for Melissa. Multiple episodes of UTI and sepsis every time she had chemotherapy. Multiple times her fistula clotted every time she had sepsis because she would have hypertension and that fistula would go down. And so at this point, we were left with a hard option. What do we do with those kidneys? And so no other form of kidney disease do you take out kidneys. We do here. But it's not an easy option. These kidneys are big. They have complications. Do you go ahead with that surgical risk? What if you take out one kidney and the other kidney is infected? You could still have UTIs. Do you take out both kidneys? If you take out both kidneys, guess what? It's going to be on dialysis the next day. But you can improve quality of life. Maybe they can be transplant candidates if the infections go away. And these are really indications for native nephrectomy. And in her case, it was the recurrent or severe kidney infections that were the cause of it. And there's no guidance of when to do this. You can do one kidney, you can do both kidneys. You can do unilateral kidney pre-transplant, you can do bilateral pre-transplant, you can do one before, you can do one after. You can do it laparoscopically, you can do it open. And it's the Wild West, really. Everyone does it differently, and that's because depending on where you trained and what's available locally, you do that. But what's known is that patients who have nephrectomies consistently report improvement in quality of life. This was pre and post-transplant, nephrectomy questionnaires 12 months apart in those who had unilateral and bilateral nephrectomies. And whether you used an ADPKD specific score or the SF26, doesn't matter, scores improved in everyone. And 94% said they actually go in and have those nephrectomies again. So it is an important thing to remember that it is a last resort to manage pain and infections, but it is a resort. That's Melissa's kidney.
Oh, God.
So that's one. She had two of them removed. She had to have both removed because of the sepsis, and we didn't want to take a risk with the chemotherapy that we left her kidney with infections in. So she had a dialysis catheter placed, and she also had a PD catheter placed because you can still do peritoneal dialysis even if you take out the kidneys long term. Unfortunately, 3 weeks later, she was diagnosed with malignant pleural effusions and metastatic cancer. And she wanted to rapidly transition to PD so that she could actually do PD at home and be at home because she had metastatic breast cancer. And I don't know I hope it helped her quality of life because that was the text she sent me a few weeks later. She says, 4 cycles of chemo and no urinary tract infections. So I hope we helped. But again, this is just to focus that PKD is a lot more than GFR decline. Yeah. And we really need to be the quarterbacks as we manage a lot of these symptoms. There's just so much guilt, so much mental complications that come with it, so much anxiety and depression, the guilt of passing it on. I have patients who come to me and say, I can't go to Pilates classes. People keep asking me if I'm still pregnant. There's a lot of concern about it. So you really need to have a good psychosocial team to help you. You need to have psychiatrists. You need to have centers where you can have comprehensive multidisciplinary care. You need to individualize this. You really need to follow up and assess their care and educate these patients that they have options and they have a lot of treatment teams and specialists who can help. And that's why it's really important. And that's why the PKD Foundation in the last few years has been pushing this concept of developing these centers of excellence. And this is a map that I put up here. I've been fortunate enough to help kind of lead this program and develop it from the last 4 or 5 years. You can see we have about 83 centers nationwide, 40 COEs. I don't see one here yet. Exactly. So this is a good time. This is a good time to build a program. A lot of patients, over 15,000 patients have been treated in these centers. And this is where they get this comprehensive care. And just remember that you need a team to manage PKD. It's not just the nephrologist, but we really have to take charge. So I'm not going to spend too much time on my closing thoughts, but really PKD is common. You have tools to risk stratify. You can modify the course of disease. We have one drug, offer it to patients who can't take it. Consider genetic testing if you want to identify risk and talk about prognosis. And we're further waiting on data from lifestyle and other diet-based therapeutics. But the complications, remember that they are just as important as preventing kidney failure. And you have all the tools in your armamentarium there, including taking out the kidneys to help these patients. Don't think that you're putting them on dialysis because quality of life actually improves. We have data from patients. Lots to be done. I'm happy to chat about PKD all day long, but thank you for listening. So, That's Melissa. You might be wondering why I have a patient's photo up there, but Melissa's always wanted me to tell her story. Melissa died last year in April, and she and her husband always wanted me to tell her story and said, please put up my picture. Her husband today comes to me even now and says, if you have patients who want to do PD, I will help train them because I've essentially been her nurse all along. So again, it's a small net community that's really powerful. But yeah, happy to talk. Thank you.
Fantastic. So I take a little bit of chair prerogative here just because it's an area of interest for me. And there's so many good. So a pathophysiologic question, a clinical question, and regulatory questions, just two of them real quick. But I obviously would comment first being the vegan cardiologist that everything's better with plant-based diet, everything from mTOR, you name it, and you did. And so the cardiology experience is that keto diet improves risk factors short-term, but the increase in inflammation and LDL long-term after 12 months increases mortality. So I'm hoping that we don't have a 12-week outcome like you measure and take that as definitive.
Right.
And nice randomized trial, perhaps?
Yes. So great points. And that's why I think, we've been very, very careful about saying, yes, keto works or yes, keto do it, just knowing what we know from cardiology. And the fact that there are all these uric acid and all the complications that can lead to more stones and acute issues also. So Europe is doing this. There's actually a phase 3 trial size. So that's being done right now, looking at keto diet. So hopefully in the next 2-3 years, we'll at least have 2-3 year data in these patients. So that'll be beneficial to look at. But yeah.
So in view of the time, I think I'll skip half my questions and just go to the regulatory stuff.
Okay.
Why does India have the pill cost 90% less than the United States? What can we do about that? Is American Society of Nephrology, anybody going after the pharmaceutical industry and trying to change that for our patients?
Oh, that's like an onion. We need to unpack. Yeah, that's right. So we are working on that. Obviously, right now, in the US, we cite development and drug development costs as being one of the leading causes of keeping that up so that everyone has access to it. There's the complications with all our pharmacy benefit managers who are taking things off. But the other thing is that at least in India and stuff, the developing country benefits that they get from having to either remodel the drug or change some of the, I would say, the exact pattern of that drug so that they can get it off label sooner has been a practice. And what the other thing we've seen is that so much of drug production has moved overseas. I mean, India is like the vaccine capital of the world. We develop most of the vaccines. So they've managed to get non-patentable drugs off cost for a long time. But I think we have, at least in the kidney space, we are passing regulation to bring down costs in patients who have dialysis needs to get some of these drugs. Because like you said, we can develop them, but if patients can't get them, they're completely useless.
Exactly. So my last regulatory question is, looking at that curve,
yes.
Why do we allow the FDA to approve this tolvaptan for rapid progression? Why wouldn't you start earlier?
Well, great question. I think the point is they needed to measure some outcome, right?
Yeah.
And if you started, because GFR decline really starts only at 30s, 40s, I can have a Mayo 1E patient who's 20 years old. I know they're high risk.
Yeah.
And we said, and how do you predict that? You can predict that now using the Mayo classification. So the TKV came out earlier, and now we say that the Mayo classification that tells us about the TKV will allow you to identify people who are high risk. So you don't need to wait for the GFR decline. I can find a 20-year-old who has massive kidneys, and their GFR is completely normal, and I'll start them on tolvaptan.
And insurance will pay for it.
Yes, absolutely. So you do not have to see. So if you are in intermediate risk, you need to have evidence of GFR decline. So you need to have something else because of that Mayo 1B, 1C. So if you're in that intermediate range, you need to have that plus at least a year of GFR decline. But if you've got Mayo D or E, whatever your GFR, I put 18-year-olds on tolvaptan, I put 20-year-olds on tolvaptan. So I'm trying to prevent that kidney function decline 25 years from now. So,
fantastic.
Yeah.
Go to the group.
Just a quick question then. How many people do you think come off the drug from side effects in your clinic?
once you down titrated to make sure that they're drinking enough water, even a low dose tolvaptan. I've had, probably 2 to 5% at most come off the drug. Most patients take it. It's a very different population, the PKD population. They're driven, they want a cure, they're willing to do anything. The number of patients who come to me saying, when's your next trial? I'll join a trial is incredible. So that's why I think, it behooves us to offer what we can and, move the needle on helping them.
There's a couple. Oh, sorry. Go ahead, Dr. Dar.
If you have a class 1B patient, how frequently do you repeat their imaging?
Oh, great question. So, there isn't a clear-cut guidance on how often. We know that not all patients are necessarily linear, but most of them don't end up changing classes either. So if I have a 1B bang in the middle of that B band, they're probably never going to get to a 1C. But if I've got that 1B, upper 1B getting close to a 1C, probably about 3 years is when I would recheck an MRI.
Yeah, I have a couple of questions real quick from our chat area on Zoom. From Dr. Emmons, he's one of our blood marrow transplant specialists. Says, which genetic modification technology is closest to clinical utility in ADPKD? Is it CRISPR, antisense, or any other?
So I think the antisense oligonucleotides right now are the closest. We have one in trials, and I know of at least 2 or 3 companies that have molecules in preclinical to phase 1 development. There's another company called Vertex, which I had on that slide, which is developing a polycystic modulator. So they're actually going to modulate the gene itself to prevent misfolding. So some hope, but these are at least 5 years away from even large human trials.
And one more real quick, actually, from Dr. Ennis. What's the most common cause of death for patients with ADPKD who undergo renal transplant?
Cardiovascular disease. As with all patients with kidney disease and kidney failure. Number 1 cause.
Are the number of de novo cases with gene mutations going up, or is there any study that looks at that?
That's a great question. I actually don't know the answer to that. I would say that if anything, they would probably not. I don't expect that to change. I mean, unless you think that there is a trigger causing a mutation, because we know that even mice that have the hit somewhere in that early developmental phase, something changes and then you have the development of cysts. So unless we have a trigger that we identify that is causing that to happen de novo in patients, I don't think we know that it's going up or down.
Because it's kind of a big gene, I think.
It's a huge gene.
Yeah,
so PKD1 especially is a really big gene, and it's very, very difficult to sequence. And that's why we also get a lot of missed genetic mutations, because it's so big. Sometimes we have deep intronic segments that get completely missed. You've got copy number variations that prevent you from identifying the PKD1 gene. So when I have patients who this smells like PKD, it talks like PKD, it walks like PKD, but the gene test commercially is negative, I send them over to the Mayo for research testing. I can't put that in the chart. I'm like, because it's not clear certified, but I know that these patients have PKD, and very often the lab there is able to identify new mutations. And I think that's important for us, because this is how we move the field. This is how I go back to my commercial people and say, you're missing this. Can you get this on your next version of the platform, or can we classify this VUS? So that's helpful to know.
Well, it's been actually amazing.